watch both. Um, this one's probably not going to be as long, but that's my fault. But okay, so this is chapter 43, GU. So I made a table because I like tables. When I can make one, I make one. I think they help me understand things better, especially because I'm making it. So, there's two major GU disorders and have to really do with the kidneys. And the first one I want to start with is acute post-infectious glomerulonephritis or APIGN or AGN. So, acute or sudden inflammation of the glomeruli in the kidney results in acute renal failure, and it's very rapid, right? It's going to be this very rapid, really acute renal failure. And this is preceded from a streptococcal infection of the throat or skin that was not treated or cured. That was 10 to 14 days prior. So, in other words, that's why for children who have strep infections, it is crucial to emphasize making sure they continue their antibiotics for the full course. Because if they don't, or maybe the antibiotics didn't work, right, or they only took half of it, they're at risk for this. They're at risk for potentially acutely damaging their kidneys. And how do we know that they have this? Well, there's three really major symptoms. One being that they have a sudden onset of painless hematuria or blood in the urine. That's going to be this tea-colored, cola color, bright red. Know that. The next one is going to be proteinuria, or we're going to see protein levels in the urine. And they're going to be hypertensive. Those are our three giveaways that they have acute post-infectious glomerulonephritis. Other things include mild edema, decreased urinary output related to the renal insufficiency, fever, fatigue, lethargy, headache, yes, but these are your main ones, the painless hematuria, the proteinuria, and the hypertension. You could do PPH if you have to make a cute little mnemonic, but we're looking for that. Now we're talking about acute renal failure. So we are already expecting to see elevated BUN and creatinine levels. We're going to have a decreased serum protein or hypoalbuminemia because they have proteinuria. It's going out. The protein's leaving the body through the urine, which means it's going to decrease. They're going to have an elevated anti-streptolysin, ASO, which indicates that they had a previous streptococcal infection. They're going to have an elevated ESR. I would know these labs. Also, the ultrasound is going to show enlarged kidneys. Urinalysis is going to show hematuria, proteinuria, and RBCs. Okay? Makes sense, right? They have blood, they have hematuria, they're going to have a urinalysis indicating that they have RBCs in their urine. Treatment and medications, it's really just based on the symptoms. So we know that they're hypertensive, they're going to get antihypertensives like nifedipine or labetalol. Furosemide may be used, especially if they have mild edema or to help with the blood pressure. Antibiotics, penicillin type, know that. Potentially, if this acute renal failure happens and it's not treated immediately, they can go into chronic renal failure, and this could be, they can go into dialysis. Not good. Um, Diuresis and decreasing blood pressure signals beginning of resolution or that this patient's getting better. Know that. And lab value should return to baseline in 6 to 12 weeks. So, nursing care, right? Vital signs, especially blood pressure, daily weights, strict intake and output, and make sure you have you can give the meds, you assess labs, right? They have a good nutrition status, and we want a high protein diet. Why? Because they have proteinuria, they're peeing it out. Sodium restrictions and food restrictions may occur, especially because we're talking about acute renal failure. Sometimes too much fluid is not good, and monitoring activities. Then there's nephrotic syndrome. Now, nephrotic syndrome could be idiopathic, meaning we don't really know why. A primary cause, we're not really sure, but we know that nephrotic syndrome is a glomerular disease of the kidneys, which impairs filtration. Children, usually by 6 years of onset, get this, and it's very slow. So, acute post-infectious glomerulitis is very abrupt and sudden. Nephrotic syndrome is slow. Manifestations of nephrotic syndrome, proteinuria. Okay. They have edema around the eyes, right? So they wake up in the morning, the face is really puffy, but as the day goes on, it goes to the lower extremity. So this edema is going to move. That's why it's going to be called dependent edema. It's going to move from the face to the lower extremities. That is going to be a key sign that's going to let you know, hey, they could have nephrotic syndrome. Weight gain, if they have thick, frothy, like a lot of bubbles in the urine, That can let you know they have it. Regular irritability, intolerance, blood pressure may be elevated, may not be, but thick, frothy, a lot of bubbles in urine, edema that around the face and goes down to the periphery, proteinuria and weight gain. I would especially highlight these, right? Now you're seeing the difference between nephrotic syndrome and acute post-infectious, right? Because this one does not have hematuria or hypertension the way the other one does. And this one has a different type of edema. Lab results. We're going to see massive proteinuria for nephrotic syndrome. Makes sense. And hypoalbuminemia and hyperlipidemia. Know that. Know that. Treatment and medications. Corticosteroids to decrease the inflammation, like prednisone. Diuretics, like furosemide for the edema. And we're going to give IV albumin therapy, 25% of albumin. So nursing care, monitor daily weights. Remember, daily weights is the best indicator of hydration status. We're going to monitor activity because they're very at risk for fatigue, right? Good nutrition, make sure they have high protein. Both of them are going to have a high protein diet because they both have proteinuria. Vital signs, especially because now that these patients, the reason we want to monitor vital signs is because they're taking diuretics, right, to help with the edema, which means they can have orthostatic hypotension. For acute post-infectious glomerulonephritis, we want to monitor the blood pressure because we know that peeing a lot and decreasing in blood pressure indicates resolution or that this disease is getting better, not worse. For nephrotic syndrome, we also want to prevent infections, monitor labs, emotional support and teaching. But knowing what labs you see, what medications, and the manifestations is really going to help you know what the difference is between these two. Any questions? Okay. Well, this is going to be a very short video. That's going to be added to that, but it's also going to be there.